How are you everyone? Hope you're doing well. Today we are looking at conventional and dissociative disorders. So conventional and dissociative disorders are also known as the hysteria. It's known as the hysteria. So most of people have this condition, especially in ladies. The percentage is high and usually found in people less than 35 years. So what is the definition of conventional and dissociative disorder? So hysteria is a condition in which a patient presents with physical or psychological symptoms which occur without physical or psychological cause which is associated with. So you find that it's a condition in which there is physical or psychological symptoms that occur without the physical pathology which they are associated with. So for example, you find that someone starts convulsing without a pathology, without any disease. Someone starts convulsing. So convulsions are symptoms without a pathological cause. That's what we call hysteria. Someone starts shivering. Someone starts I can't see while they're able to see, or they don't have eye problem. So that's what we call hysteria, or conventional and dissociative disorder. So it is hypothesized that by developing the symptoms, the patient ends up by avoiding the unbearable anxiety. So you find that someone who starts saying, I'm sick, I'm having abdominal pain, when there is an exam ahead of you, and then missing an exam because of hysteria or because of the psychological or physical symptoms is known as primary gain. So primary gain is a situation where someone presents with symptoms of conventional and dissociative disorders, thereby avoiding the unbearable condition or situation. That's what we call primary gain. So the disorder are more common in female than in male and tend to begin before the age of 35. So what is the etiology or the cause of dissociative disorders or conventional disorders? One, you have emotional conflict. Emotional conflict, like one, you mayamba na kunyumba, and then you don't want to see them, or you want to punish them, and then you pretend to be sick, or you start vomiting. And then two, maladjustment to situation. So maladjustment to situation can present with the symptoms of hysteria. And then you have genetic disorder. So genetic disorders, these are just inborn or family history of psychological problems. And then we have constitutional factors. Constitutional factors, this is the way someone was brought up from childhood, which can affect the general view or behavior of the person. So those are the causes of dissociative and the other conventional disorders. So let's try to break them down one by one. We start with the dissociative disorders. So dissociative disorders, these are disorders of behavior as if the brain is not functioning properly. So dissociative, the brain is not associated with your symptoms, so dissociative. So one, we have dissociative amnesia. So in this one, the patient is unable to recall long period of their lives and sometimes gain any knowledge of their previous life or personality identity. So you find that in this one, the patient doesn't know themselves, they don't know where they are from or any history about their life. So you find that this one, you find that it's more common in people that have been faced with criminal charges. They would pretend to have forgotten everything that has happened. No, I don't remember anything. They don't even remember their personal identity. So it's what we call dissociative amnesia. And then we have dissociative phobia. Dissociative phobia is a patient not only loses their memory but also wander away from their usual surroundings, and when found, they are usually gain all memory of their whereabouts during the period of wandering, and may also gain knowledge of personal identity. So in this one, the patient doesn't only lose their memory, but they also wander away from their usual surroundings. So you find that they move to a place where they are not usually found, and when they are asked, so sometimes this one is common, where you are anxious with the people that you are meeting, and you want to gain your identity Or some people, it's a neurotic disorder. People have this disorder where they are just hysterical in their presentation. So you find that they don't know where they are going, where they are coming from. It's known as dissociative what? Phobia. And then we have dissociative stupor. So this one, the patient shows the characteristics or features of stupor as if in schizophrenia. So when we start looking at schizophrenia, you understand that stupor is maintaining an awkward position for what? For a long time. So you find that these patients, they are motionless and mute, and they do not respond to any stimulation. So you find that hey, they are not responding to anything. So, and most common in patients, people with what? Depression, you find that they have dissociative what? Stupor. So you find that there are no any problems identified so far for someone to become mute, and then have just decided to become what? To become mute. So, or motionless, like they don't move, they're just static on the same position. And then there's Gaucher syndrome. Gaucher syndrome is a condition where a patient will start giving you answers like approximately one greater or less than to the answer. So it's mostly done when you're doing intellectual functioning. Most of the patients that are admitted in psychiatric department, some of them run away from their family's problems. So they try to pretend as though they are what? They have mental disorders. So you ask them what is 2 plus 2, they'll tell you they're 5. They are just adding 1. Tell them 2 plus 5, they'll tell you 6. Just they subtract 1. So that's what we call Gaucher syndrome. So those are the dissociative what? Disorders. And then we go to conventional disorders. Conventional disorders, these are disorders that mimic the effect of physical illness. So in this one, the patient will mimic the symptoms of physical what? Illnesses. So one we have with motor symptoms or defect. So this patient will present with motor defect or symptoms such as psychogenic paralysis. So you find that they will start telling you, like I'm not able to feel anything on this hand. And then there is also tremors. They'll start shivering, and then the mutism, they can be quiet, and then they feel like they have a lump in the throat. When you touch them, there is nothing. So those are the conventional disorders. They mimic physical what? Illnesses. So you start thinking, maybe because the patient has paralysis, the patient has stroke, the patient has hypothyroidism. No, all those things are just conventional disorders. So that's what we call with motor symptoms. And then with sensory symptoms or defect. So with sensory symptoms or defect, you find that the patient will present with anesthesia. Sensory, they are not able to sense anything. So they can be saying, I can't feel anything, I can't feel my legs. And then paresthesia, they'll stay with it. I'm just feeling numbness on the certain part of the area. When you do CT scan, MRI, it's negative, everything is okay. Then hyper anesthesia, they can feel pain. They start screaming as though there is so much pain, but there is no physical illness. And then they can blindness, they'll tell you that I can't see. When you do visual acuity, it's okay. They'll present with those symptoms. And then with the other one is with seizures or convulsions. In this one, the patient presents with psychogenic convulsions that can be distinguished from epilepsy in 3 ways. So these are the 3 ways that you can differentiate that this is hysterical or it's convulsions or seizures that are secondary to brain pathology. So one, the patient does not become unconscious, though he may inaccessible. So the patient will not become unconscious, but they will pretend to be what? Sleeping. And then 2, the pattern of movement does not show a regular or stereotype form of seizures. So normally when someone is convulsing, you find that there's arrhythmic convulsions like seizures, regular ones. But in this one, you find that vaindeko fast, vaindeko slow, chani, they don't mimic the real convulsions. That's why that's how you can differentiate the psychogenic convulsions. And then there is no incontinence, and then there is no cyanosis because the airway is patent, and then no injury or bite of the tongue because the patient is pretending. So that's it on the conversional and the dissociative disorders. Those are the signs and symptoms and the the difference. Dissociative talks about the psychological or brain defect, and then conversional talks about physical illness. The patient mimic physical illnesses. And then apart from that, we have epidemic hysteria. Epidemic hysteria is a condition where you find that there is a large group of people presenting with the same signs and symptoms, usually secondary to an incident that has occurred. For example, I'll give an example of the recent incidents that we had about gassing. So you find that in a certain compound there is a history that there are gassers, and then you find that in the hospital you find a lot of people coming that our house has been attacked. When you do chest x-ray, you do stethoscope, the chest is okay, the airway is fine, but they'll tell you that I'm not breathing well. So you find that it starts from one person and then it spreads to different type of people. So that's a epidemic type of hysteria. It can also occur in students. Usually the symptoms that are common is fainting and dizziness. So you find that when they are about to write an exam, the student faint. So they're trying to get primary gain from conversion dissociative disorder. So that's what we call epidemic hysteria. How do you manage? How do you do management? So management talks about first investigations. The investigations that you can do: history taking, identify family history or any anxiety situation ahead. And then physical examination, you can identify and differentiate between the pathological or psychogenic symptoms. And then you can do lab tests like full blood count, CSF to rule out meningitis or cerebral diseases. And then you can also do full blood count to rule out any infections. And then urinalysis can be done to rule out UTI. And then you can do MRI, CT scan, and X-ray to identify pathological causes or to find differentials. And then treatment, you cancel. Canceling is the first thing that you do. So you cancel the patient depending with the presenting signs and symptoms, and then closing the institution in case of epidemic hysteria. And then carry out appropriate investigations throughout physical causes like I mentioned earlier. And then do not neglect a patient. Sometimes these patients will come, yes, present psychogenic symptoms, but you need to find out and do extensive investigations throughout the problem presented. And then you treat anxiety as a form of anxiety. You give an anxiolytics like diazepam. So that's how you manage a case with hysteria. So hysteria is known to be a common case, but it can be a pathological or neurotic disorder in psychiatry. Most people may present it as a normal or trying to run away, but they don't know that they have a psychological problem. So they need counseling, they need all those interventions that we have mentioned. Normally, if admitted, you can do these other tests like you can do the nursing care, the prophenema. You include psychotherapy, you include counseling, you include prevention of injury, and then you can also include prevention of injury, and those are things that you know that we can include in management of a patient and dissociative and the associative disorders. Yeah, thank you.